Okay, why don't we get started? I know a lot of you guys. I'm Merritt Cullum with Southview Cardiology. We're going to be talking about a huge topic today of heart failure. Just trying to summarize kind of the general approach to treatment and some recent advances in medical therapy. So, in the interest of disclosure, I do speak for Astellas Pharmaceuticals as well as Novartis, who does manufacture a drug we're talking about called Entresto. However, these are not going to be proprietary slides in any way, shape, or form. So what are we going to talk about today? The epidemic of congestive heart failure, the causes of heart failure, what does guideline-directed medical therapy look like, as well as new advances in the treatment of congestive heart failure. These, after about a 10-year lull where we had no significant advances in medical therapy, we've just had 2 this year that have come to the market, and it's exciting. So let's talk about the epidemic of congestive heart failure. 1 to 2% of the generalized population in developed countries has heart failure. It's common as we get older, and particularly diastolic heart failure greater than 70 years of age. About 10% of people have it. It's a progressive syndrome that results in poor quality of life as well as a huge economic burden. All you have to do is go to 5 West as well as our cardiac ICU, and you will see this problem. The fact of the matter is that we've gotten really good at treating hypertension compared to the days of FDR when he died of a brain bleed, as well as most patients survive heart attacks. I think I treated my 88-year-old next door neighbor last week with an anterior STEMI, and she was home in 48 hours. So most people survive heart attacks as long as they get to the hospital in a timely fashion. Patients have identical symptoms from both systolic as well as diastolic heart failure, and we'll talk about that later. The guideline-directed medical therapy has led to a tremendous improvement in survival. Before 1990, 60 to 70% of patients with heart failure died within 5 years. With evidence-based medical therapy, the same mortality has been reduced to 20 to 30% at 5 years. So our pills do work. We do have ways we can improve medical therapy, but they do work. So, the basic pathophysiology of congestive heart failure, particularly systolic dysfunction, is an underlying insult to the cardiac insult, such as a heart attack, leads to maladaptive changes in the surviving myocytes, which in turns to remodeling, enlargement of the left ventricle with dilation and impaired contractility in the case of systolic heart failure. In turn, there are a bunch of inflammatory markers that are released, as well as activation of the renin-angiotensin-aldosterone system. And in fact, serum adrenaline and norepinephrine levels have been shown to directly correlate with the degree of left ventricular dysfunction as well as your risk of dying related to systolic heart failure. So this is I forget which one's my laser, maybe this one. This is a schematic from the New England Journal showing an underlying cardiac insult, which in turn leads to left ventricular remodeling, this neurohormonal imbalance, increased cytokines, inflammatory markers, etc., as well as apoptosis, which is programmed cell death. This in turn leads to electrical problems of the heart, ventricular tachycardia, ventricular fibrillation, even atrial fibrillation, as well as renal dysfunction, all sorts of downstream effects. Which in so left ventricular dysfunction does not mean somebody has heart failure. Congestive heart failure is a clinical syndrome based on symptoms. So common precipitants of heart failure: atrial fibrillation due to loss of atrial contraction or atrial kick, a left bundle branch block. It's a question of whether that's a cause or a consequence of heart failure. This is due to loss of synchronized contraction of the left ventricle. This is how we, this is the rationale behind biventricular pacing to synchronize electrically the heart. Anemia due to additional hemodynamic load on the left ventricle, which can lead to high output cardiac failure. Obviously not taking your medicines is a common one. Dietary indiscretion of sodium and water. If patients eat potato chips and pickles once they get out of the hospital for heart failure, they're going to be right back usually. This is actually a big one, over-the-counter medicines. Non-steroidals are a big, big problem. In fact, they're so unsafe, if they had to get FDA approved in this day and age, they probably would not be approved. But these over-the-counter cold and flu preparations, many of which have decongestants in them, as well as these herbal preparations like Ma Wong. I remember I saw somebody who ended up dying of a brain bleed from malignant hypertension from Ma Wong as a resident. So they're not benign. Complications of heart failure, worsening of symptoms, either due to progressive pump dysfunction oftentimes, declining functional capacity, frank decompensation requiring hospitalization, electrical arrhythmias, particularly ventricular tachycardia and ventricular fibrillation, as well as premature death. The mechanisms of death. In class 4 heart failure, they usually die of progressive pump failure. Rats, keep hitting the wrong button. Progressive pump failure. Patients with New York Heart Association class 2 often die of ventricular arrhythmias if they don't have a defibrillator in place. Okay, etiologies. This is a busy slide, I know. In the developed world, coronary disease is the most common cause, particularly in African American patients. Hypertension is a close second. Patients with diabetes can develop a cardiomyopathy even in the absence of obstructive coronary disease. Viral Coxsackie virus is relatively common. The thing to know about alcohol abuse is that with good medical therapy and cessation of alcohol, a lot of times left ventricle can return to normal. This is the chemotherapy, particularly doxorubicin, but some other cancer drugs. This is an emerging area of interest. A lot of academic centers are developing cardio-oncology clinics and looking at things like myocardial strain to try to prevent. A lot of this is dose-related, particularly with doxorubicin or adriamycin, and so we're a lot more careful about the dose that women get, particularly for breast cancer treatment now. But while doxorubicin is the most common, there's others like Herceptin and a number of these medicines that are potentially cardiotoxic. Cocaine is a common cause of cardiotoxicity as well. And then Chagas disease, a parasitic disease in South America. Now, diastolic heart failure, which is normal squeeze of the heart, stiff, impaired compliance of the heart with progressive increases in left atrial pressure. The most common cause is hypertension, often exacerbated by atrial fibrillation in people in their 60s, 70s, 80s, and 90s. Infiltrative cardiomyopathy such as amyloid, Wilson's, hemochromatosis are relatively rare. Okay, so symptoms of heart failure: dyspnea, paroxysmal nocturnal dyspnea, meaning feel fine till you lay flat in bed and you wake up in the middle of the night gasping for air. Orthopnea, meaning you have to sleep at more and more of an angle so that you don't feel short of breath. Fatigue, and then chest discomfort, which can imply obstructive coronary disease, but you can also have chest discomfort, I found, when the left ventricular filling pressures are elevated. I commonly hear that, and even though they've had normal catheterizations, normal arteries by cath. So the signs of heart failure: elevated neck veins, jugular venous distension, enlarged PMI, an S3 or an S4, extra heart sounds, hepatojugular reflux when you mash on the liver and see reflux in the internal jugular vein, peripheral edema. These are specific but not sensitive signs. How do we evaluate these patients? EKG, chest x-ray, basic labs, including a TSH, sometimes uric acid, as well as a surface echo. Because they have identical signs and symptoms of systolic and diastolic heart failure, the only way you can tell the difference is with an ultrasound of the heart. And it also excludes secondary causes of heart failure, critical aortic stenosis, which you'd hopefully hear a murmur on, mitral regurgitation, things of that nature. But it also allows you to look at the size of the left atrium and to non-invasively and with no risk evaluate the structure and function of the heart. All right, coexisting conditions that lead to heart failure. We talked about ischemic heart disease, hypertension, diabetes, dyslipidemia. Atrial fibrillation can be a result of heart failure. It's kind of the chicken or the egg phenomenon. We don't know which comes first oftentimes. Cachexia. I just had an 86-year-old gentleman in the hospital with biventricular dysfunction. His wedge pressure was 35 and he had a big V wave, meaning he has significant mitral regurgitation. He was wasting away, not eating, as soon as we put him on IV diuretics, and his gut was no longer congested. His appetite came back and he looked great and felt great, lost 15 pounds. Gout can be secondary to the diuretics. Renal dysfunction is common, particularly when patients are on diuretics. And anemia is also quite common. And almost all these patients have some form of sleep disorder breathing. Probably just about every heart failure patient should be considered for a sleep evaluation, or nearly everyone. Okay, this is another New England Journal slide just showing what we're looking for, why you do an EKG to make sure they're not in atrial fibrillation, make sure they don't have QRS prolongation, make sure they're not too bradycardic as you're titrating beta blockers, chest x-ray to look at the heart size, and then all these other tests, CBC, and then looking at their potassium, BUN, and creatinine. Hyponatremia is also quite common in heart failure patients, and there are certain medical therapies to correct that now. Okay, so there are two different clinical classifications of heart failure. One is New York Heart Association. This is functional classification. How does the patient feel? And then the ACC-AHA stages of heart failure. Now the functional classification ranges from class 1, they have no or minimal limitation, to class 4, they can't do anything without getting short of breath, with class 2 and 3 falling in between. Stage A, which I rarely use truthfully, is patients at risk for heart failure but they don't actually have it. Stage B is those who have structural heart disease but they don't have symptoms. Stage C, they have weakened heart muscles and they have symptoms. And then stage D is they have advanced heart failure. And these are the patients we're considering for left ventricular assist devices, heart transplant, things of that nature. Okay, busy slide kind of going through this. These are patients with risk factors: hypertension, diabetic, obesity, metabolic syndrome, sleep apnea. But they don't actually have underlying structural heart disease. Their ventricles are normal, at least for now, but they're at high risk. These are the people you need to get to early in prevention, say, we've got to change your ways. Stage B, they have a weakened heart muscle, but they don't necessarily have symptoms, and these are the people we put on medical therapy: ACE inhibitors, beta blockers. Stage C, they have known heart disease, had a previous heart attack, hypertensive cardiomyopathy, whatever. They have weakened heart muscles, they have symptoms. They're also on the ACE inhibitors and beta blockers. Then we also talk about put them on diuretics, things of that nature. And then stage D, those are the people we're considering for left ventricular assist devices, transplant, things of that nature, advanced heart failure therapy. Okay, so ejection fraction does not correlate with symptoms. I have patients in my practice with an ejection fraction of 10 or 15% and they feel fine. I have patients in my practice with an ejection fraction of 45% and they have class 3 bordering on class 4 symptoms. So your ejection fraction, that's a common misconception. Ejection fraction does not correlate with symptoms necessarily. Okay, so when we talk about pharmacologic therapy, I describe this as it's kind of like making soup. Treatment of hypertension, treatment of heart failure is like making soup. You have to have the right ingredients and the right doses, and you got to let it cook and steep for a while until it finally tastes good. Same thing with heart failure. We put patients who have symptomatic heart failure on diuretics to relieve symptoms to get to their so-called dry weight. Now on the floor, I found that ins and outs are not reliable and they're not really helpful. So daily weights are the best. If they're losing weight on a daily basis, they're more out than in, and that's what you want. Now, some patients, particularly if they've had long-standing heart failure and they've been on large doses of diuretics for a long period of time, you start putting them on higher doses of furosemide or bumetanide or Lasix Bumex, they don't really have much of a diuresis. And so there are other, we talk about sequential nephron blockade, so not just working in the loop of Henle, but working in the distal collecting duct and the aldosterone receptor to cause sequential nephron blockade. So this is a thiazide type diuretic called metolazone, and then we also have spironolactone or eplerenone working more distally. Now there was a dose trial in the New England Journal about 10 years ago looking at low dose versus high dose diuretic therapy, as well as continuous drip of diuretics, put them on Lasix or Bumex drip versus intermittent IV Lasix. And it showed really no difference between bolus versus continuous infusion of IV diuretics, or that low dose versus high dose strategy doesn't necessarily work better. And so you want to give the patient the lowest dose of diuretic that you can to get them better and to get them decongested, because you run the risk of worsening their kidney function. And this did show a slightly increased, with continuous IV diuretics, the renal function got slightly worse. In high dose diuretics compared to low dose diuretics, the kidney function got slightly worse. But this trial did conclude there was no difference in assessment of symptoms or change in renal function between low and high dose diuretics or intermittent versus a continuous drip. Incidentally, please feel free to stop me at any time if y'all have questions. We can also take questions at the end. So I'm going to talk to you about an exciting new aspect of heart failure now, which is combined neprilysin as well as renal angiotensin system inhibition for the treatment of heart failure. Now we know that the myocytes have all these natriuretic peptides, an atrial natriuretic peptide in the atrium, BNP, which is mostly secreted in the ventricle, and the CNP, which is not much secreted in the heart actually. The ANP is released in response to increased atrial pressure. The BNP is released from the ventricle as a result of increased LV filling pressures. And there's increased expression of these in hypertrophy of the ventricle. These natriuretic peptides are secreted in response to plasma volume, increased volume, as well as LV filling pressures, which is common in heart failure patients, and they regulate sodium and water balance. So these natriuretic peptides in and of themselves are a good thing. They maintain your water balance, prevent you from going into heart failure. Now, in the not so distant past, we had Nesiritide, which is Natrecor, which is an intravenous exogenous synthetic BNP. It did make patients less short of breath, but it also led to low blood pressures, and there were safety concerns about people falling and things of that nature. It was administered intravenously. You had to do it in the hospital. It was expensive. It didn't have any effect on reducing heart failure morbidity or mortality. The Ascend trial showed no reductions in death or heart failure hospitalization in 30 days, as well as a non-significant reduction in dyspnea. And so it's fallen out of favor, and it's real expensive. And so hospital administrators don't like it, with good reason. Now I'm going to talk to you about this new substance that just came on the market this summer. It's called, it was formerly called LCZ696. It's a combination of an ARB with a neprilysin inhibitor, and the trade name is called Entresto. So, this was developed by Novartis. This substance called LCZ696, which is sacubitril with an ARB called valsartan. What it was found to do is inhibit this neprilysin enzyme, which in turn breaks down these natriuretic peptides. So by inhibiting neprilysin, it prevents the breakdown of these natriuretic peptides, which are good for the heart, and they cause vasodilatation, lower blood pressure, reduce sympathetic tone, and also lead to natriuresis and diuresis. So loss of sodium, which means you lose volume. So this was approved, FDA approved, based on this one multinational trial called Paradigm Heart Failure. It was over 8,000 patients, had to have an EF of less than or equal to 40 with class 2 to 4 symptoms, had to be on stable doses of ACE inhibitors, ARBs. They were on, 95% of them were also on beta blockers. The endpoint was a composite of cardiovascular death and heart failure admission, and it was terminated early by the Safety and Monitoring Board due to the overwhelming evidence supporting this new substance, LCZ696. The findings were that it reduced the composite endpoint by 20%, which was, and it reduced, it wasn't just less, it was 10% reduction in heart failure hospitalization and 10% mortality reduction. And so that was what led to its approval, was this overwhelming evidence. It also reduced all-cause mortality, not just cardiovascular mortality, by 16%. Hypotension is slightly more common with sacubitril valsartan compared to the ACE inhibitor control. And across the subgroups, which were underpowered to show a difference, there were similar findings favoring this substance. So to put this into context, LCZ696, which is sacubitril valsartan, result in a similar incremental mortality reduction as SOLVE treatment trial in the 90s, which is what led to the approval of FDA approval of ACE inhibitors. So the thought leaders all across the world are predicting that this twice-day therapy, trade name Entresto, will probably replace ACE inhibitors and ARBs for the treatment of heart failure. That's why it's such an exciting time. And now that's for systolic heart failure. It's being studied in hypertension. It's also being studied in diastolic heart failure. We don't know those results yet. I'm also going to talk to you about another thing that was just approved this year. Ivabradine, or Corlanor is the trade name. It blocks the funny current. I always thought that was a good name. This is basically the cardiac pacemaker current, which regulates heart rate. It has the most pronounced effect on the SA node. This drug has 3 doses given twice daily. It does prolong the PR interval slightly on the EKG. It was FDA approved on the basis of one trial as well, the SHIFT trial of over 6,500 patients who had class 2 to 4 systolic heart failure, bad ventricles, and they were in sinus rhythm with the resting heart rate greater than 70. They had to be on good and stable medical therapy, as you see, and it was titrated to basically cause a slower heart rate. And what this trial showed is that this substance Ivabradine reduced the risk of the combined endpoint of heart failure or cardiovascular death solely through reducing heart failure. It basically had no effect on mortality and had no statistically significant benefit on cardiovascular death. I truthfully have not had much experience with this. I don't know if anybody in the room has. Most cardiologists are looking for a drug that helps you live, not just keeps you out of the hospital, but actually makes you live longer. And so it is an exciting new therapy. It will help get people out of the hospital. The problem I have with it is that heart failure patients are already on at least 5 or 6 medicines, and so this is adding yet another one. We're going to talk about guideline-directed medical therapy. Truthfully, we've already begun to touch on that. As I said, the best analogy I can draw is that treating heart failure, it's kind of like making soup. You got to have a bunch of ingredients and then you got to let it cook for a while. What I mean by that is that these volume overloaded patients, they need diuretics, and then once they're decongested, we're putting them on ACE inhibitors and beta blockers or ARBs or this new LCZ696. In African American patients, we'll talk about fixed dose hydralazine with Isosorbide Dinitrate, which is the hydralazine is an afterload reducer, the nitrates are a preload reducer. And then if patients still have refractory symptoms and they don't have bad kidneys, we can talk about placing them on aldosterone antagonists. So kind of a stepwise approach is how we go about this. So again, busy slide, don't expect you to remember any of this, but here are the ACE inhibitors as one aspect of treatment, or the ARBs, not both, one or the other, not both, as they work. They have similar mechanisms of action. The combined ACE inhibitors with ARBs lead to renal dysfunction and potassium problem, hyperkalemia, and then beta blockers. And then if they're still having refractory symptoms in spite of that, I consider the aldosterone blockers. Spironolactone is generic now. The most common side effect is gynecomastia, painful breasts, which is what led to the development of eplerenone, which was approved in patients who'd had heart attacks, and it led to mortality reduction, but it's, last I checked, it was a lot more expensive, and so price is a concern. Okay, so ACE inhibitors, this was based on the SOL trial from the 90s. Reduce ventricular size, increase ejection fraction, reduce symptoms, reduce your risk of a repeat heart attack if you've already had one. And these are for patients who have symptomatic as well as asymptomatic left ventricular dysfunction. ARBs, angiotensin II receptor blockers, similar efficacy to the ACE inhibitors. They were more expensive. I'm not sure that's still the case, as a lot of them are generic now. Usually, because these weren't directly studied as first-line therapy, if patients develop a refractory cough with an ACE inhibitor, I'll put them on an ARB next. They're not usually placed, patients not usually placed on ARBs in addition to ACE inhibitors and beta blockers because of the risk of renal dysfunction and potassium problems. Beta blockers, it's hard to say what's truly first line and what's second line therapy. If I see a heart failure patient, I'm making sure these patients are both on an ACE inhibitor and a beta blocker at the same time, really. I guess technically beta blockers are first line therapy, as well as for asymptomatic as well as symptomatic heart failure, regardless of cause. They had a significant, across the board, they've had significant mortality reduction. There are three beta blockers that reduce the rate of admission, hospital admission for heart failure, as well as improve mortality. Only 2 are FDA approved in America. Carvedilol, which is Coreg, is the trade name. Metoprolol succinate, which is Toprol XL. Bisoprolol, which is the beta, is not FDA approved for heart failure in America. So this comes up all the time. Somebody gets admitted, they're swollen, they're congested, they're 20 pounds over body weight, ideal dry body weight. What do you do with their beta blockers? If it's a new diagnosis, we diurese them first, then you start a low-dose beta blocker and upwardly titrate as an outpatient. If it's an old diagnosis, you can continue the same or maybe reduce the dosage and then diurese the patient. We try not to stop their beta blockers unless their heart rate or blood pressure is simply too low, because there is evidence that you can actually increase someone's mortality if you stop their beta blocker while hospitalized. Aldosterone antagonists, we talked about these, we touched on these. There are 2, spironolactone, which is aldactone, is the trade name, eplerenone, which is Inspra. This is reduced symptoms, readmission rate for heart failure as well as mortality, class 3 to 4 heart failure patients. Eplerenone, which is Inspra, reduced mortality in patients status post-MI. Aldosterone has less eplerenone has less gynecomastia, but it's more expensive. Again, because you're putting patients on multiple drugs that act in the kidneys, you've got to pay close attention to their potassium and renal function either as an inpatient or as an outpatient. Every one of my heart failure patients who gets admitted, they get BMP, Chem7 every day. And you should avoid any of these medications if they have chronic kidney disease stage 4. Fixed dose hydralazine and isosorbide dinitrate has been shown. We know that African Americans have an inferior response to ACE inhibitor therapy compared to Caucasian patients. In self-identified African Americans, treatment with fixed dose of hydralazine and isosorbide dinitrate in addition to standard therapy reduced hospitalization for heart failure, improved quality of life, as well as increased their survival. And so this traded drug called BiDil is an expensive formulation of 2 old generic medications. And so if cost is a problem, you can just use the generics. It's a little bit harder, and dose isn't quite the same, but it's very close. Digoxin is an old drug. It's been given for a long time. In patients who have in sinus rhythm with systolic heart failure, digoxin reduces the risk of rehospitalization, but has no effect on mortality. The problem is in these patients who often have renal dysfunction is it has a narrow therapeutic index, which means it's really easy to get toxic. It's not usually effective as a single drug for rate control of atrial fibrillation, except at rest. You really got to be careful in elderly patients with this. They can start talking out of their heads and get toxic, and it's kind of fallen out of favor for these reasons. I still use it if I can't get the rate controlled with atrial fibrillation. Dr. Cox might have more experience with it than I do, but we do have better alternatives now. The one thing we do know is that you should use low dose, either 0.125 milligrams daily or every other day. The 0.25 milligram daily, particularly in elderly patients, is probably not the best idea. Inotropes are effective in patients with class 4 heart failure when you have no other option, but they unfortunately increase your mortality and increase your risk of ventricular arrhythmias, particularly ventricular tachycardia, ventricular fibrillation. Dobutamine, which is Dobutrex is a traded name, and Milrinone or Primacor are our options. These are the patients that we want to use for cold and wet patients, meaning they're in pulmonary edema, but they don't, their extremities are cold, their systolic blood pressure is 80, 90s, 100 tops. Milrinone is renally excreted and requires dose adjustments and renal dysfunction. Also Milrinone, which is Primacor at high doses, causes vasodilatation, which can lead to hypotension. So the cold and wet patient, which is a really hard patient to take care of, where their lungs have crackles, their systolic blood pressure is 80, 90. Those are the hard ones to take care of. If they're warm and dry, meaning their lungs are clear, you don't really have to worry about diuretics. If they're cold and dry, you actually might give them a little bit of volume cautiously. If they have adequate systolic blood pressure, they probably just need diuretics. Atrial fibrillation, very common in heart failure patients. And these patients can be very hard to maintain sinus rhythm, and particularly one of the maladaptive changes of heart failure is that the left atrium, where atrial fibrillation usually arises from, progressively enlarges, both as a consequence of left ventricular dysfunction as well as secondary mitral regurgitation, leaking into the mitral valve. The paradox, therefore, is that these heart failure patients can be the hardest to restore sinus rhythm due to left ventricular dysfunction, yet they benefit the most from restoring sinus rhythm. The AFFIRM trial was an old trial, about 15 years old now, from the New England Journal, that showed no benefit of maintaining sinus rhythm as compared to rate control and atrial fibrillation for all comers. In terms of antiarrhythmic therapy, there are really only a couple options: amiodarone, which is cortisone, as well as dofetilide, which is Digoxin, dronedarone, which is Multac. Basically, the way I think of it is amiodarone without the iodine in it. Is actually contraindicated in decompensated heart failure. It increases mortality. It's also not as effective as amiodarone. The problem with amiodarone is it has a bunch of non-cardiac toxicities, lung problems, skin deposits, eye deposits, thyroid dysfunction. So I don't like long-term, particularly high-dose amiodarone. You can get you can still get thyroid problems, skin problems, even on chronic low-dose amiodarone. So we try to get patients off of this. Digoxin, which is dofetilide, is a class 3 antiarrhythmic. You got to go through a course to prescribe it. It's got to be done for 48 hours in the hospital. Have to monitor their renal function, get daily EKGs to make sure you're not prolonging the QT interval. Anticoagulation. So a lot of times we don't routinely place these patients on blood thinners unless they have atrial fibrillation, unless you see a clot in the left ventricle. Prosthetic heart valves, your only option if they're mechanical heart valves is warfarin, Coumadin with low-dose aspirin, but not these newer drugs have been developed for atrial fibrillation. If they have a history of a left ventricular thrombus, your only real option is a heparin product, either enoxaparin or unfractionated heparin, as a bridge to warfarin with target INR between 2 and 3. Okay, so this is just from JACC, from Journal of American College of Cardiology, looking at an approach to atrial fibrillation. A lot of times while these patients do benefit from sinus rhythm, they're really hard, and you have to just say they're going to be in permanent atrial fibrillation, and we're going to rate control them and put them on an anticoagulant. There may be some role for cardioversion, even atrial fibrillation ablation in these patients. Certainly the sooner you do it, the better, unless they have a huge dilated left atrium. The more dilated the left atrium and the longer the atrial fibrillation, the less chance you're going to get them back in sinus rhythm. Okay. And this just shows that ablation, where ablation may fall in. Okay. Certain medicines to avoid in heart failure. NSAIDs. What these do is they alter the prostaglandin balance in the kidneys. They can actually, I've seen this numerous times where somebody gets some ibuprofen for pain, and all of a sudden their creatinine goes from 1 to 4. They're in acute renal failure and getting dialyzed. What I tell all my heart failure patients is you can take the medicines I prescribe. If you have a headache, you can take Tylenol. Anything other than that, I want to hear from you. Thiazolidine diones of Andia. Dr. Nissen at Cleveland Clinic, this was his passion for about 5 or 10 years to get that taken off the market because it was unsafe in heart failure, or try to get it taken off the market. Calcium channel blockers can worsen your peripheral edema as well as left ventricular dysfunction and can actually precipitate congestive heart failure. You should avoid inotropes except in class 4 heart failure patients with marginal blood pressures as they increase your mortality. Defibrillators, most of these patients on good medical therapy who have had a heart attack, they're at risk for sudden cardiac death, usually due to ventricular tachycardia and ventricular fibrillation. The patients with more severe symptoms, class 4 patients, more often die due to progressive pump failure. But defibrillator therapy to treat malignant ventricular arrhythmias is indicated for primary prevention in patients with class 2 or 3 heart failure with an EF of less than or equal to 35. On good medical therapy, you have an adequate life expectancy. You have to wait at least 40 days after STEMI, as well as 3 months from a new diagnosis of non-ischemic myopathy. If somebody has survived sudden death, they certainly should have a defibrillator implanted. Cardiac resynchronization therapy. What we know is that patients who have bundle branch blocks, what happens is the septum is electrically, the anteroseptum is activated first, followed by the lateral wall milliseconds later. And this can in turn lead to secondary impaired emptying of the left ventricle as well as secondary mitral regurgitation. Cardiac resynchronization therapy, which is placing 3 leads, one in the right atrium, one in the right ventricle, as one in the coronary sinus to pace the left ventricle, synchronizes the heart, which increases cardiac performance by increasing your stroke volume and reducing the mitral regurgitation from dilatation of the annulus, as well as electrical desynchrony. Again, a busy slide, but patients, and then actually now we're implanting defibrillators, including biventricular defibrillators in class 1 patients, not just class 2 and 3. Class 4 patients really has to be done on an individualized basis to see what you estimate their mortality to be in the short term, given this is a very expensive therapy. So, patients with left ventricular dysfunction need some kind of ischemic evaluation. Most of the time we perform heart caths on them. If they have kidney problems, we can talk about maybe doing a nuclear stress test. It's more controversial about when to talk about bypass surgery versus stents. A lot of it has to do with the particular details of their anatomy once you've done a heart catheterization. There was a stitch trial which showed in patients who'd had previous big anterior MIs with anterior wall aneurysms, there was no benefit of left ventricular reconstruction to put some sort of containment device to reconstruct the left ventricle called a Door procedure. There was no benefit of left ventricular reconstruction to standard bypass surgery. And as I said, patients that have bad kidneys, chronic kidney disease stage 4, where you're worried about the contrast dye, we consider a nuclear stress. The fact of the matter is you can do a heart cath with 15 cc's, 20 cc's of dye if you have to, so it's not that much of an issue, really. Disease management programs do work. We certainly rely very heavily on our, we're a team here, and that nurse educators, case managers, social workers, home health nurses are all critically important as we're trying to keep these patients out of the hospital. As you know, both hospitals as well as physicians, I don't believe, are now reimbursed if a heart failure patient gets readmitted within 30 days. So we have to find a good way to keep these people out of the hospital. Part of that's having the physician see the patient in the office in a timely fashion, but a lot of that also, the home health nurses can really help us out a lot. The key, as always, is education about heart failure, what to eat, what you can eat, what you shouldn't eat. I usually tell these patients, drink when you're thirsty and stop when you're no longer thirsty, and 2 grams of sodium, which is pretty hard to do. But it's, they shouldn't, no added salt to your food. Processed foods are real bad for you. Obviously, potato chips, pickles, all that, pork rinds are not your friend in this disease. Oops. And this just, oh rats, that's out of place. We've already kind of touched on this anyway. I'm just showing you kind of an algorithm of how we go about thinking about all this. Diastolic heart failure, stiff heart syndrome. Third of patients with heart failure have normal ejection fraction. This is particularly common as we get older. When Dr. Cox and I read echocardiograms, diastolic dysfunction or impaired relaxation of the left ventricle is almost ubiquitous, particularly in people in their 50s, 60s, 70s. It actually has a similar mortality rate compared to patients with systolic heart failure. So it's not more benign, even though the squeeze of the ventricle is still preserved. So this refers to an abnormality of diastolic distensibility, filling or relaxation of the left ventricle. Or diastolic heart failure is symptomatic heart failure, shortness of breath with exertion. Diastolic dysfunction in turn means there's abnormalities of filling of the left ventricle. If they develop effort intolerance and dyspnea, that's diastolic congestive heart failure. We don't know really what causes it. It's common in long-standing hypertension, particularly if it's uncontrolled. It can also be seen in infiltrative cardiomyopathy such as amyloid, which are pretty rare. It's also very common in patients with atrial fibrillation. So this is a New England Journal echocardiogram just showing that what you have with diastolic heart failure is thickening of the ventricle with preserved systolic function, and then progressive enlargement of the left atrium relative to a normal echocardiogram. And what this does is it shifts the pressure volume loop up into the left, this right there. And so the patients require less volume for a given pressure, and the consequence is breathlessness. So, as we've talked about several times now, the clinical features, the signs, and the symptoms are identical. The only way to tell the difference is to get an echocardiogram. What you're looking at is what is the ejection fraction, what is the left ventricular mass and left ventricular thickness, as well as the left atrial size. But they have identical clinical presentations. This shows, when Dr. Cox and I read echocardiograms, what we're looking at is the E wave, which is passive left ventricular filling, and then the A wave, which is the component of left ventricular filling from atrial contraction, left atrial contraction. And what this leads to is progressive increases in left atrial pressure is the net result of abnormal filling of the left ventricle. Here are all the positive trials we have in diastolic heart failure, none. So we really don't know how to treat it other than by a team of so-called experts. It seems to make sense, though, that we want to reduce congestion with diuretics, control blood pressure aggressively, slow the heart rate down to allow time for adequate left ventricular filling. Perhaps if they're in atrial fibrillation, we'll try to get them out of atrial fibrillation so they can regain the atrial contraction component of cardiac output. And if they have myocardial ischemia, the first sign of myocardial ischemia when you look at an echocardiogram is actually diastolic dysfunction before you have wall motion abnormalities and all that. So, to conclude, heart failure is a very common diagnosis supported by echocardiographic findings. The mainstays of treatment are the ACE inhibitors, the beta blockers, diuretics, both potassium loop diuretics as well as potassium sparing. We talked about guideline-directed medical therapy, what that looks like. It is thought that this combination of sacubitril and valsartan, which is the trade name is Entresto, may replace the ACE inhibitors and beta ARBs as first-line therapy. We need to search for the cause in the developed world. Most of the time this is coronary disease, can be valvular heart disease, can be non-ischemic myopathy from hypertension or cocaine abuse. Diastolic heart failure is also quite common, particularly as people get older. There are no randomized trials to guide our treatment, but it seems to make sense that we should control blood pressure, slow the heart rate down, perhaps get the patient back in sinus rhythm, diuretics if they have pulmonary edema. Fortunately, infiltrative cardiomyopathies are rare. That's a good thing because they're very hard to treat. And with that, I know I've talked fast. Y'all don't want to hear me talk for a long period of time, so I'm glad to hear any questions, and I'll try to come up with an answer.